Good morning everyone. Welcome back to JMRight Academy, and today I'm very happy to discuss about the story of pediatric population after a very long time. Yeah, pediatrics are not just miniature adults, they are specialty population. So they are taken care of for their physical, mental and social well-being right from birth till the adulthood. So this is it's special. And they are not just little human beings. They have different body composition, they have different pharmacokinetic parameters, and they have various parameters to be monitored very carefully. So why pediatrics are important? Nearly 20 to 25% of world populations are pediatrics, and the acute and chronic diseases can affect these population. You would have known about the thalidomide and sulfanilamide tragedies, yes? Yeah, sulfanilamide caused many deaths, and thalidomide has caused birth defects among the children in whose mother took thalidomide for morning sickness. This has led, at this stage has led pediatrics focus more, and then this has led to the amendment in 1962 in which the safety before the drug approval in pediatrics is important. And this amendment has made the industries less interested towards the drug approval of pediatrics. And this has led to the pediatrics as therapeutic orphans, because most of the drugs are used to them are not established, they do not have established safety and efficacy. It's purely based on the evidences, and this concept has made clear that it's important to create more evidences among the pediatrics. It's important to monitor their drug properly. It's important to have individualized dosing adjustment. So for these to be known, as a student, we must know the basic things, what are the most common drugs used, what are the most common diseases which are seen among the young adults and the pediatrics, and what are the most common drugs which need therapeutic monitoring, and what are the areas, and which drugs require special counseling to the parents, and which drugs need the counseling part in a very specific way, and which drugs need drug adherence. So these all areas will be covered today as two parts. First part will be taken today. So who are pediatric population? Neonates, infants, children, adolescents. They are said to be pediatric population. So neonates include from the time of birth till 28 days. They are said to be neonates. And then who are infants? So after 28 days, that is 29th day till 2 years of age, they are said to be infants. And then children from 2 years till 12 years, they are said to be infants. And then 2 to 12, then 12 to 21, they are said to be adolescents. So who are premature infants? So from gestational age till if the child born before 30 weeks of gestation, that is gestational age, they are said to be premature infants. And what is gestational age? So the gestational age is from the time period between the time of conception till birth, that is said to be gestational age. So we will be seeing about the absorption, distribution and excretion, the pharmacokinetic parameters which differ particularly in pediatrics. The first thing we are going to see is absorption. So in absorption, the first parameter is the pH. So coming to the pH, infants have a pH of about 5. So when they are taking acidic drugs along with milk, that may decrease the absorption of acidic drugs. and because the pH will be raised. Already infants have a pH above 5, and then giving acidic drugs with higher pH will decrease its absorption. Now moving on to the gastric emptying time. So gastric emptying time, when meperidine is given along with acetaminophen. So meperidine is usually an inappropriate drug for pediatrics until the age of 18 years. But in case of emergency situation, so meperidine is a pethidine, which is an opioid analgesic. When given to the pediatric population, it decreases the gastric mobility. So when there is a decreased gastric mobility, so gastric emptying time will be, what about the gastric emptying time? When there is a decreased mobility, gastric emptying time will be increased. So when there is an increased gastric emptying time, so when paracetamol is given along with this drug, it increases the peak plasma concentration time in by acetaminophen. So it increased time will be taken to achieve the peak plasma concentration by acetaminophen. So next one is about the gut colonization. So gut flora is an important concept, and then gut flora is usually decreased in infants when compared to adults. So you will be all knowing about the digoxin, which is a narrow therapeutic drug. So this narrow therapeutic drug will increase its viability of this drug will be increased. Bioavailability will be increased in infants when there is a decreased microbial flora, that is gut flora. So more keen therapeutic monitoring of digoxin is necessary, especially in infants, due to this reason. Now we are going to compare intramuscular, percutaneous and rectal absorption with infants and adults. So how it will be in intramuscular absorption is actually it is more in infants and children. So when you give benzathine penicillin G to the infants, there will be better absorption in infants when compared to adults. How we can, this is actually a theoretical one, and how we can practically confirm is that when you check the benzathine penicillin G activity after 18 days of injection, there will be no activity. So it indicates that the benzathine penicillin G is completely absorbed through intramuscular route. And then moving on to the percutaneous route of absorption, it is also increased in infants and children. And then you will be seeing a rectal absorption. So rectal absorption, here we have seen all the disadvantages, some of the disadvantages, but in rectal absorption there is an advantage. In febrile seizures, the rectal solution of diazepam is better absorbed when compared to suppositories. So it will be very much useful in febrile seizures in infants and children, which is very common. And in case of percutaneous absorption, I forgot to tell, it's Enlg, that is eutectic mixture of lignocaine and prilocaine when it is given. So it actually, there will be an increased percutaneous absorption of prilocaine, and which reduces the methemoglobin reductase. When methemoglobin reductase is reduced, there will be increased methemoglobin, so which leads to methemoglobinemia in infants. So it's a disadvantage. If you want to know about the basics of absorption, distribution and metabolism, you can check the link above, and you can just check the playlist of the drug teacher and you can understand the basics. So now check the body water, just compare the body water in premature infants and adults. You can very well notice that a total body water percentage is more in premature infants when compared to adults, and even the extracellular fluid is more in infants when compared to adults. So this is a difference. And what should be the dose of water soluble drugs in pediatrics, whether it should be increased or decreased. So here the drugs are water soluble, and here the body water is high in infants. So when there is an high level body water, and for water soluble drugs they generally require increased dose, because when there is a high body water there will be high distribution. Water soluble drugs have a larger volume of distribution. So larger volume of distribution will make the drugs to distribute throughout the body, and so the water soluble drugs must have a higher loading dose per kg when compared to adults. So infants require a higher dose of theophylline. And next, body fat. So what would be the body fat for pediatrics? Whether it will be less or more? It will be less in pediatrics. So what should be the clinical effect of highly lipid soluble drugs? Whether it will be increased or decreased. That is, whether the clinical effect of lipid soluble drugs will be there for a prolonged period of time, or it will be for a less period of time. Here the body fat is less. You must know the concept of redistribution. So redistribution is nothing but the lipid soluble drugs initially will be moving to the areas with higher blood flow, and then they will be redistributed. Here the concept is distribution. Here redistributed to the lower vascular regions, that is the bulkier tissues, that is fat. Here the pediatrics have lesser fat, and hence the drug from the plasma will not get reduced, it will remain the same, and hence the prolonged effect of lipid soluble drugs will be seen in infants due to the fact that they have less fat. For example, thiophental action will be seen for a longer period of time. And then the protein binding. What about the protein binding? So one is body water, and then fat, and then protein binding. So proteins are generally synthesized in liver. So which drugs bind to these proteins? So albumin and alpha-1 acid glycoprotein. The drugs bind to usually these proteins, and albumin is the major protein which helps in the binding of drugs. And most of these proteins are synthesized in the liver, and neonates, the liver is not completely developed, and hence the concentration of protein will be less, and affinity of protein to the drug will also be less. So concentration and also the affinity will be less. So what is kernicterus? It is related to the protein binding. Just you can think kernicterus is nothing but the excessive levels of bilirubin which crosses the blood-brain barrier. So for example, if you are giving the highly protein bound drugs to infants, and here that drug bind to albumin in a greater percentage. So and bilirubin also binds to albumin with higher rate. So when you are giving highly protein bound drugs, this highly protein bound drugs compete for albumin with bilirubin. They compete, but then bilirubin sometimes win, and highly protein bound drugs sometimes lose. And whereas very highly protein bound drugs just compete with albumin, and they will bind to the albumin, leaving the bilirubin aside. So the bilirubin levels in the blood will be raised, and that crosses the blood-brain barrier, and it causes kernicterus. For example, phenytoin and caffeine. These are two drugs that are most commonly used in pediatrics, and when these drugs are given, it must be monitored closely. So the next, moving on to the excretion. So famotidine, nearly 80% of the drug, that is H2 receptor antagonist, is excreted unchanged in the urine in infants, whereas renal clearance will reach the stage of similar to adults when the child reaches 1 year of age. And then coming to the most common conditions, what are the common diseases or conditions seen in children? First one is, you all will be knowing, respiratory tract infections, asthma and viral infections, acute gastroenteritis, and you have a PDA, that is patent ductus arteriosus, ventral septal defect, and you'll be seeing juvenile rheumatoid arthritis. So these are the most common conditions you'll be seeing in the hospital, and you can get thorough about these diseases and the drugs used in these diseases. And what are the common drugs seen in the department? So first one is regarding antibiotics, injections, ceftriaxone, that cephalosporins and amikacin will be commonly used, and inhalers will be used, that is budesonide and levolin, that is levosalbutamol. These are the commonly used inhalers. And You'll be seeing injection paracetamol and even suppository paracetamol, and tablet aldactone, and syrup furapet, that is furosemide, and you'll be seeing cherry cough syrup. You will be seeing like the injection methotrexate, and when methotrexate is given, a folate will be given. So these are the most commonly used drugs in this department. You can see the doses available and their forms and for which condition is given. We'll be talking about various inhalers, the counseling points. The first one is Rotohylas. Hold the Rotohyla vertically and position the two holes of the Rotohyla such that fin is not directly below the rotacap hole. Okay, this is the fin and it's not directly below the rotacap hole. Remove the rotacap from its bottle and insert it into the rotacap hole with its transparent end facing downwards. Third step is to hold the mouthpiece firmly with one hand and rotate the base. Fourth step is to breathe out fully and place the mouthpiece of the Rotohyla between your teeth. Close your lips tightly around it and tilt your head slightly backward and breathe in through the mouth rapidly and deeply. Hold your breath for 10 seconds or as long as possible for you and you are comfortable, and then breathe out normally. Open the Rotohyla and dispose the empty capsule. You can continue to use the Rotohyla daily up to 6 months and discard it and replace it with the new one. Now you are going to see about the metered dose inhalers with mouthpiece. Remove the cap from the inhaler. Shake the inhaler well for 5 seconds. Insert the inhaler into the adapter section of the spacer. Ensure proper fit. Sit straight or stand up. Since it's a mouthpiece, place the mouthpiece into the mouth and close the lips around it. Ensure a good seal. Breathe out gently and press the MDI, that is metered dose inhaler, at the beginning of slow inhalation. Breathe in slowly and deeply for full breath. Hold for up to 10 seconds. Wait for 1 minute or longer if another dose is needed. If it is for a metered dose inhaler with a mask, same procedure, but place the mask over the nose and mouth. Ensure a good seal. Breathe in and out normally for about 6 breaths. Remove the mask from the face. So if it is for if another dose is required, wait for 1 minute or longer. So that's all for today, and next class you'll be seeing about the incompatibility problems which arise in the pediatric department, and then off-label drugs, ADRs, and drugs which require therapeutic monitoring, and you can see about the nutritional deficiencies in children. So these all will be seen in part 2, the pediatrics, drugs in pediatric department. So if you would like to watch about the drug related case studies, you can check in the playlist, and I have put the link above, and you can check it, and you can like